Hello and welcome to the AABIP podcast. On this podcast, we go one step beyond publications and guidelines to speak directly with leading experts in interventional pulmonology. This podcast will address not only fundamental topics in exciting publications, but also unconventional topics for which the evidence base isn't that robust. The views expressed on this podcast are those of the speaker and not necessarily endorsed by the AABIP. This is your host, Udit Chadha, an assistant professor at the Icahn School of Medicine at Mount Sinai. And with that, let's dive into the next episode.
So with us today, we are fortunate to have two very renowned guests. Our topic for discussion today is cryobiopsies and diffuse parenchymal lung disease, and I could think of no two better experts to dissect this down than Dr. Maldonado and Dr. Lentz. Dr. Maldonado is an associate professor of medicine and thoracic surgery and an associate professor of mechanical engineering at Vanderbilt University Medical Center. Dr. Lentz is an assistant professor of medicine and thoracic surgery, also at Vanderbilt in Nashville, Tennessee. Thank you, Dr. Maldonado and Dr. Lentz, for joining me today on the podcast. If you both can please clarify if you have any conflicts of interest.
So I have received an unrestricted educational grant from IRB for research purposes, and that would be my only conflict of interest with this.
Yeah, I don't have any.
Thank you, Dr. Maldonado and Dr. Lentz. So let's get started by discussing the yield of cryobiopsies in patients with DPLDs. So approximately 50% of patients with UIP can be diagnosed on HRCT, but the rest will need a biopsy. Dr. Lentz, am I correct in saying that the main reason to obtain histology in DPLDs is to diagnose or rule out UIP?
Well, I think that is among the things that we're most interested in. So although I think diagnosing diseases that are not UIP are still potentially important, but I think a lot of the interest in the field right now, especially as we have new antifibrotic drugs, and much of this is focused on UIP, is to rule in or out UIP as the entity that tends to have among the worst prognoses and has prognostic information for the patient, and that also has specific treatment available at the moment. But I think there's still some utility in considering, even in patients that with scans, high risk CTs that are not compatible with UIP. I think there's still some utility in sampling those patients to see if there's specific therapies available to them.
So how good are cryobiopsies? What is the overall diagnostic yield for cryobiopsies, and how well do they do specifically with UIP?
This is a difficult question because there's the issue of diagnostic yield, there's an issue of diagnostic accuracy, and there's an issue with just how we define and diagnose diffuse parenchymal lung diseases in general, which has historically been based a lot on pathology, although there's a reason now that pathology is not the gold standard for diagnosis, and it's a multidisciplinary committee discussion because pathology is not everything in these diseases. And then the other issue with this literature is that there's been, everybody does this procedure a little bit differently, or potentially a lot of it differently, with respect to how far from the pleura they're biopsying, what probe they're using. I mean, the basic principle is the same, but there's a lot of variation around the edges that matters potentially here, and that will play into diagnostic yield for different things. I think in broad strokes, what most folks, with most of the larger papers or series or meta-analyses, whatever, has come up with is it's somewhere in the 70 to 80% range. The caveat to that being that, especially a lot of the early literature, was if you found like anti-fibrosis, they counted that as a hit, which is not a very, I think, accurate way to look at things. But the more recent, especially in some of the older, but especially some of the more recent papers, especially the largest series to date, which is Ravaglia and Paletti's 700 patient series that was recently published, where they ran all these patients through multidisciplinary committee and got a diagnosis, a confident diagnosis of 90%. That's pretty good. Now they might do it. They have the biggest volume and they've done this a lot, and so your mileage may vary at smaller centers that are just picking this procedure up. But I think when it's done right, this procedure, while probably not as good as surgical biopsy, is a reasonable chance of getting a diagnosis in a less invasive way.
Fantastic. Thank you. So we know that MDTs are the gold standard to diagnose PTLDs, and pathologists often change their diagnosis based on clinical and radiographic information. So Dr. Maldonado, please clarify this for me. Histopathology for DPLDs isn't all black and white. I mean, do pathologists also need to form a differential diagnosis like clinicians and radiologists?
Right. Yeah, I think that's a really good question. And so, you're right to say that pathologists will change their diagnosis based on the overall impression from clinician and radiologists too. So I think about 20% of pathologists change their diagnosis in the original Sarti paper, which is that kind of landmark study that evaluated the contribution of sequential addition of information, clinical, radiological, and pathology to the confidence in the diagnosis and intersurgical agreement. So what we know of ILD is that if you put a bunch of experts in the room from pathology, from the clinic and from radiology, they ultimately reach a consensus that has pretty good confidence. So the issue is that just like as a clinician, we look at a patient and we formulate a differential diagnosis, the radiologists do the same thing, the pathologists do the same thing. So any kind of study, and we'll talk about the Romagnoli paper, I'm sure, soon, any study that will ask pathologists to have one diagnosis and stick with it and compare this to whatever standard is going to be almost nonsensical, right? So the only good way to analyze this with all the caveats and limitations of the multidisciplinary discussion, we'll call it silver standard, but yet accepted as the way to formulate a formal diagnosis for ILD. With all these caveats, the best way to analyze the contribution of cryobiopsy to the diagnosis is to look at its contribution to the multidisciplinary diagnosis discussion and just compare it to surgical lung biopsy. And this study was done. It was done by Sarah Tomassetti. It was published in the Blue Journal. This is, in my view, the only reasonable paper that looked at cryobiopsy, and what we found, or what they found, is that cryobiopsy and surgical lung biopsy have exactly the same contribution to the diagnosis of ILD, which means two things. One is that they're both completely useless, or they're both pretty good, or anything in between, right? And so that's really where we are right now. We don't really know whether any kind of biopsy contributes to improved patient outcomes. What we know is that in us, clinicians, radiologists, and pathologists happy because we've reached a diagnosis, we've labeled the patient with some kind of diagnosis, but as far as whether we've done any good to the patient, we don't know. There's no study today, which is amazing, that has looked at what happens to the PSPs of patients that are submitted to any kind of biopsy for ILD, which is crazy to think about it. And certainly no study today that has shown any improvement in patient outcomes after biopsy. So that's the question right now. The question is not really cryobiopsy versus surgical lung biopsy. There's a little bit of a vendetta against cryobiopsy from a minority, a vocal minority in the ILD world in particular, but the same minority grants some strength immunity to surgical lung biopsy, which makes zero sense because that's a dangerous and maybe unethical procedure to do in patients with ILD.
Yeah, and I'll add a couple things here, if that's okay. So one point on the Tomassetti paper that was surgical biopsy or cryobiopsy's contribution to MDC, about 50% of the patients in that study actually were diagnosed with UIP. So getting back at earlier questions with how good is cryobiopsy for UIP, I mean, it's difficult to say that with certainty, but certainly in a lot of these centers that are doing a lot of these, we're diagnosing a lot of UIP with this procedure. And then the other thing, getting at Fabian's question about or point about biopsy and outcomes, the only data of which I'm aware, which is not super strong, but we published a letter in Journal of Thoracic Diseases earlier this year where we looked at all the patients at our site who had been diagnosed with IPF and went on to go on to antifibrotic therapy. That was about 175 patients. And then we looked at how they got their diagnosis. Was it by high-res CT? Was it by cryobiopsy? Was it by surgical lung biopsy? And the patients who were biopsied, which may not be the exact same as the patients who were diagnosed by high-res. They were a little bit younger. They were a little bit more robust as far as comorbidities, although their PFTs were the same in all three of these groups. Patients who were biopsied and then went on to antifibrotic therapy lived about 2 to 3 years longer. And whether we are whether those patients are different cohorts and we're seeing that, or whether a biopsy will allow earlier diagnosis before your scan gets bad enough to be diagnostic of UIP, we don't know. But maybe some hint that early biopsy in some patients might lead to better outcomes.
I would argue here that it's pure lead time bias, which is diagnosing these patients before they get to terminal fibrosis, which is the typical UIP radiologic pattern. So jury's still out, but that paper is pretty good actually. It kind of replicates what's been done before for surgical lung biopsy, showing that patients who undergo surgical lung biopsy do better than patients who don't and are diagnosed on the basis of a typical high-res CT, but that of course is because they've got an atypical CT, so it's not as bad as the typical UIP CT.
Perfect. Fantastic. So just again to clarify the previous point, correct me if I'm wrong. So we have 3 tiers of differential diagnoses coming up, one from the pathologist, one from the clinician, and one from the radiologist. And then we all sit down, we have a discussion called the MDD to come up with the most likely diagnosis. So it's probably this large dependence on human subjectivity at 3 levels to come up with a diagnosis as one of the main reasons as to why it is challenging to come up with consistent results across cryobiopsy studies. Would that be a fair assessment?
Yes.
Okay.
Great assessment.
Perfect. So let's move on to the histological gold standard, surgical biopsies. And Dr. Maldonado just alluded to Romagnoli's paper in the Blue Journal. In this paper, 21 patients underwent cryobiopsy, immediately followed by VAC surgical lung biopsy at the same anatomical locations. The overall concordance between surgical lung biopsy and cryobiopsies was only 38%. And cryobiopsies would have led to different treatment and surgical lung biopsies not being performed in 52% of the patients. Dr. Maldonado, you wrote an interesting response to this paper, and you've alluded to some of these points in your previous answer. But can you please summarize for us what are some of the methodological issues with this paper?
Yeah, I mean, I think the paper had good intentions. I think that's reasonable at the time they designed the study. A reasonable study to design. There's a couple other studies that are about to come out that have a similar methodology. The issue, of course, now would be to say, why in the world would you submit patients to dangerous procedures like this at all? And so, but that's an entirely different story. It's easy to play kind of Monday morning quarterback here. There's a number of limitations, but the most obvious one is that it's a tiny study, and in this tiny study, there were 4 cases in which the cryobiopsy was non-diagnostic, and I don't understand what that means because I've never had a cryobiopsy that did not biopsy something. So right there, it should tell you that there's some technical issues to begin with, and these 4 cases should not be included in any kind of analysis, which they were actually. And so the other issue I think with this study is that it begs the question, right? When we say that cryobiopsy does not correlate well with surgical lung biopsy, therefore cryobiopsy is not as good as surgical lung biopsy. Well, that doesn't really mean anything because, of course, you don't sample the same areas. Try to sample the same general areas, of course, but you're always going to have some sampling error, including with surgical lung biopsy, and it should be telling you something that neither cryobiopsy nor surgical lung biopsy correlated well with the multidisciplinary discussion, and that to me is a big problem in the study. The only way, and that's not my analysis, that's Athol Wells' analysis. Athol is obviously doesn't need introduction. He's like super famous ILD expert in the UK. His analysis of this is that really, in order to compare cryobiopsy to surgical lung biopsy on this very limited data set, you need to look at these few cases where cryobiopsy and surgical lung biopsy are discordant, and you need to do a maximum chi-squared test, and if you do that, you get results that are absolutely not significant. In other words, there's no significant difference between cryobiopsy and surgical lung biopsy. So concluding anything from this paper other than cryobiopsy and surgical lung biopsy together don't look all that great because they don't correlate well with multidisciplinary diagnosis. I think that's probably the only conclusion we can draw from that study.
And alluding to your previous point that there were two patients who had UIP with cryobiopsies, but NSIP with surgical lung biopsies, that still probably means that the cryobiopsy was right because UIP trumps NSIP.
That would be my guess. And I know Tom Colby very well as a pathologist, his former Mayo colleague and incredibly talented guy. There's no question if you called UIP on cryobiopsy, it was most likely UIP, and so that tells you that surgical lung biopsy is not perfect. I mean, surgical lung biopsy is not as good as an explant, right? So it's nice to have a big chunk of tissue, but as long as you don't take the entire lung and look at the entire lung, you're always going to have sampling errors.
Perfect. Dr. Lentz, so as interventional pulmonologists, what is the best we can do? What is the optimal tissue size we should try to obtain to confirm this spatial heterogeneity that we need to diagnose UIP?
I think in most of these studies that are publishing either cross-sectional area or greatest diameter of cryobiopsies, it's in the range of 5 to 10 millimeters, and that seems to be, if you take a surgical lung biopsy slide and kind of carve out 1 or 5 to 7 millimeter chunks of it, that tends to be enough for the pathologist to see the heterogeneity that they need to. I think the key is getting, we know from some of these papers out of Paletti's group that multiple sites is better than one site, multiple segments is better than one, or multiple lobes is better than one, and more than one biopsy matters. And so I think a lot of us doing this are getting in the range of 5. Eventually there's more risk to getting more, and where that happy medium is, I'm not sure. My personal practice is to go for about 5 good biopsies in that range of size, 5 to 10 millimeters. And that seems to be sufficient, at least in our practice here, and we've got 200 something cases now to diagnose. Our personal yield in our center is about 75%. So I think that's the goal, and there's a lot of variation, I think, between centers on whether you biopsy right against the pleura, whether you come back a little further, what probe size you use. All of these things make some difference in size, but I think that should be the desired size, or somewhere in the neighborhood of just shy of a centimeter for biopsy, and get multiple of them.
Awesome. So let's move on to the complications. So bleeding rates with cryobiopsies are variably reported. Dr. Lentz, if I looked at your GTT article in 2017 and cherry-picked the papers that use the bronchial blocker, the median bleeding rate is 0%. So what is the true bleeding rate with cryobiopsies, and how do we define this if we use the recommended technique of using a bronchial blocker and not biopsying more than 1 centimeter away from the pleura?
You're right that in the vast majority of publications so far, and no one is using a standardized bleeding scale, because there's not really a great standardized bleeding scale for bronchoscopy. Certainly not one that can account for the use of a prophylactically placed bronchial blocker. There are a few scales out there, and that kind of confounds most of them. And so it's hard to tell from the existing literature how people are grading their bleeding. I think most of these papers have suggested when a bleed that was physiologic in consequence happens, and I think that's what most of these papers are grading as somewhere in the nature of a moderate to severe bleed, and that seems to be in the range of 5 to 10% in the majority of these papers. But there isn't standardization that needs to be there as far as how we assess and report bleeding. I think for this procedure, it's something that we need to do better with. And I think it's certainly, given the data that we have, we started doing biopsies here before blockers were common practice. We had several significant bleeds. We've used blockers ever since. I think there is no reason not to use a blocker in this procedure. It absolutely is required, I think, to safely do this, and it works really well. It's easy to place. There's different mechanisms that you can do it, different blockers out there, but it's straightforward to do, and there's no downside to it, and it works quite well.
Perfect. Thank you. So let's briefly discuss what the near future has in store for cryobiopsies. There are 2 interesting direct comparison trials that I am aware of that have a very similar design. The first was at 4 centers in the U.S., and in this study, patients undergoing VAC surgical lung biopsy were first made to undergo 10 conventional transbronchial biopsies and then 5 cryobiopsies in the same anesthesia setting. The outcomes assessed included diagnostic yield, tissue quality, and safety. Due to challenges in recruiting, the study only has 16 patients, and this study is currently pending publication. And a similar study, abbreviated as COLD-ICE, at multiple centers in Australia, consented participants for both surgical lung biopsy and cryobiopsy, again within the same anesthesia episode. Specimens were blindly assessed by 3 pathologists, both individually and by consensus, and importantly, each tissue sample was considered in conjunction with clinical and radiological data within a centralized MDB. Dr. Maldonado, could you please tell us why these studies are extremely important for the future of cryobiopsies to diagnose DPLDs?
Well, I think they're important because, they are looking at what ILD experts are telling us the gold standard should be for the diagnosis of ILD, which is that multidisciplinary discussion. And so they are going to look at the respective contributions of cryobiopsy and surgical biopsy to that diagnosis. And if it so happens that that correlates well for confident diagnosis, then I think this would position cryobiopsy as an interesting alternative to surgical biopsy, provided there's not a ton of complications from cryobiopsy. That's one of the problems with these studies, is that because you're doing all these procedures in the same patient, the same setting, it's difficult to tease out, what the complications, at least after the procedure, are attributable to one intervention over the other. But if in the sequence of you doing the procedure, you do your cryobiopsy, you get a big bleed or something that precludes any additional biopsy, then that's a problem. I suspect they won't see that, but you never know. So that's a signal certainly to look for. I think this should be important studies because they'll be the last studies to look at cryobiopsy that way, right? Nobody should ever consider doing such studies anymore, just because it's just not. At this point, after these studies are completed, this will not be an ethical thing to do. Both procedures now we know have significant complications. Certainly surgical lung biopsy with best case scenario 1.7% inpatient mortality, in my view, should probably not be done anyway, and that's what you actually saw in the study here in the U.S. is that it took 5 years to recruit 16 patients. And there's a reason for that, is that people are very reluctant to getting their ILD patients through even a VATS procedure for surgical lung biopsy. So, cryobiopsy is not a procedure we like to do, and quite frankly, at Vanderbilt, we've decreased our number of procedures quite dramatically. We're still doing it. There's various opinions about whether we should continue to do them or not. I think it's fair to say that we're all eager to wait for the results of both Lonnie and Moorman and Wahidi's Lonnie Yarnes and Moorman and Wahidi's studies and COLD-ICE study to form a more final opinion about cryobiopsy. What is certainly true is that you cannot criticize cryobiopsy without necessarily criticizing surgical lung biopsy. And surgical lung biopsy was still recommended in both guidelines on ILD that came out last year from the ACITRS and et cetera, and from the Fleishner Society. In both cases, if you have a suspicion of PIP and no definitive typical UIP pattern on your high-risk disease, they recommend to consider surgical lung biopsy, and both guidelines did not make any comment as to whether cryobiopsy should be considered for lack of data. Of course, that's incredibly misleading because it gives the impression for clinicians that, you should do surgical lung biopsy as opposed to cryobiopsy. I think we've got enough accumulated data to suggest that cryobiopsies are clearly, in my opinion, safer than surgical lung biopsy. And as far as their respective contribution to the diagnosis, I don't see any difference whatsoever. So as far as I'm concerned, if I have an ILD someday, I probably won't get any biopsy, period. If I have to get a biopsy because my wife twists my arm, hard enough, I'll get a cryobiopsy done, but that's enough. Awesome. And
yeah, I think. Go ahead.
No, go ahead, please.
I was just gonna. To me, the bottom line is that when we think about doing either of these, cryo or surgical biopsy, we need to really think about how this is going to change management. Like, take a step back and see, is this really, a lot of us are interventional pulmonologists doing this procedure, hopefully, and so we are not ourselves working up the interstitial lung disease. We're being sent patients by our colleagues or other centers or whatever, who, like Fabian mentioned earlier, everyone wants a diagnosis, but at a point we also, the responsibility, it is incumbent on us to make sure that we are, if we're going to put a patient through a procedure with risk, we're doing it for the right reasons. And so, the patient with a DLC of 20%, even if you find UIP in that patient, how are antifibrotics going to help that patient? It's going to help them have more bowel movements every day, and that's about it. As opposed to a patient with, some early reticular change, maybe a family history of UIP, who's got a DLCO and TLC are in the 70% range. That's the ideal patient in my mind for cryobiopsy. They're not on oxygen. They're still functional. They've got a little bit of cough. They have the writings on the wall that something's brewing. That's the patient who benefits from antifibrotics, if anybody does, because you catch them early. Maybe this is the lead time that Fabian mentioned in this other study, but that's the patient in my mind that would be perfect for cryobiopsy. So I think taking a step back as we get these referrals and making sure that we're doing these biopsies for the right reasons and the right patient selection, I think is everything for this.
Perfect. And as we come to the end of this podcast, Dr. Maldonado, would you be able to briefly elaborate on what aspects of cryobiopsies the ongoing ACCP guidelines will be addressing?
We assembled a committee of experts probably, I want to say 3 or 4 years ago, to try to convince the ACCP to consider putting out not a guideline, because there's not enough data out there to formulate a guideline, but it's a consensus statement based on best evidence. It's taken this long to finally get a manuscript, which we're very proud of, which is currently under the final steps of review and should be out before the end of the year. In the meantime, because we wanted something to come out fairly quickly, we did have a consensus statement that was done with multiple individuals from across the world that we published in Respiration, I think last year or 2 years ago maybe, which has all the rationale and all the technical recommendations to do cryobiopsies well, and patient selection and so on that folks can refer to. And then again, the ACCP guideline hopefully will be published in just before the end of the year.
Fantastic. So this has been a wonderful and highly enlightening discussion. Any closing comments? Dr. Lentz, you want to go first?
Sure. I think my closing maybe was what I was just talking about, as far as if your cryobiopsy is, Fabian mentioned earlier, a procedure we don't love to do. This is a procedure you have to respect. This is a procedure you have to go into with thought and with forethought and planning, and especially if you are have not done it before, you're looking to introduce it to your center. I certainly think this is something that you want to go to someplace that does a lot of these to see how it's done and learn how it's done. You can't just read a paper and I think pick this up safely. That said, I think if you approach patients and consider how this is going to change their management and give thought to how the procedure is done, there's no right way to do this probably. There's multiple right ways, but finding and learning a way that works. I think it's a procedure that has potential benefit, again, as long as we're in this paradigm where tissue matters in ILD, which right now we're stuck in, and hopefully at some point we won't be. But it's something that it's a procedure that requires respect, but I think has value if all the precautions are taken.
Awesome. And Dr. Maldonado, anything to close?
Not really. I think I would echo what Rob said. If somebody's going to do cryobiopsy, they should know how to do it. It's a procedure you don't want to do without a bronchial blocker. You don't want to do it without an airway that will allow for rapid intervention if there's a bleeding. You want to be facile in putting chest tubes. There is data out there with more cavalier approaches to cryobiopsy. A weak patient through the nose. This is unacceptable. Should never be done. And so just be mindful of that. And the other thing I'll say is that I want to thank you for doing this. I think this is a great idea. I hope this podcast is successful, not just because I was part of it, but because it's a great idea. And just plug in for our AABIP membership, if folks are interested in getting involved. There's a number of committees that are going to be looking for new positions, new open positions for a variety of committees, including the research committee. So keep an eye, on that and apply if you're interested.
Perfect. I cannot thank our experts enough for their time today and the clinical pearls they have shared with us.
With that, we conclude an exciting episode here on the AABIP podcast. I hope you guys enjoyed listening to it as much as I enjoyed hosting it. Do also check out our website, theippodcast.com, and please do provide us with feedback and suggestions on what topic and which expert you want to hear next. Until next time, take care.